Afternoon, everybody, and I am sorry that I missed the morning session, but I've really enjoyed the afternoon that I was able to get and to hear about all of your successes. Juliet and I and Lisa and Jane were at a summit on living with and beyond cancer just last week or a week and a half ago when we were talking about the future, and here we are together in an event when you're actually living the future, if I put it that way. So all I can say to you is not only continue, but be brave and be strong and be ambitious and just keep going. What I've heard today and seen and witnessed is engagement, enthusiasm, collaboration and successes in what must be the toughest environment in the NHS. But it doesn't stop you, and I just think that's fantastic. The one thing that strikes me of 20-odd years in the NHS is its resilience, despite and in spite of everything. So for going future, by gosh, from the survivorship point of view, you're in such a strong and fantastic place. It's great to be back in Sheffield. It feels like home to me. It is where I came as a very junior, green behind the ears, first-year registrar, and spent about 8 or 9 years in Sheffield and the surrounding hospitals, which I thoroughly enjoyed. Place where I had our first home, my first car, and my first son was born. And people don't forget, Karen caught me in a question awkward at the end, and so it's really, it feels right and it feels good. And of course, the centre and the city where it's home of a political leader of a party that has both a heart and a brain, which I think is unusual, but there we go. Anyway, what am I going to talk about? 3 things. I'm going to reflect a little bit on where we've come from, as you've done today. I'm going to talk a little bit about where we're at nationally from the survivorship agenda, the here and now, if you like. And I'm going to talk a little bit about the future. So where were we? It is, when I took on this role, you do your homework, pending interview, of course, and you swat up on everything. And when you got through the first part of the patient pathway, then you started to want to read about survivorship, the wealth of activity that has gone on as a result of the National Cancer Survivorship Initiative that was launched by my predecessor, and ably, strongly, persistently, and thankfully supported by Macmillan over the years. It is a rich history of activity, engagement, generation of evidence, pilot activity. By now, I think we concluded we know what we want to do. And today, your activity over the last 18 months is testament that actually then it can be done. There may be more tweaking to be done in order to deal with the complexities of what the system then throws at you. You think you've got it cracked, and then we've got a reorganization, and you start again with new people to talk to, new relationships to build, and so on. But that whole survivorship piece of work that was initiated was all about quality in a world that really, even in cancer, didn't quite get it, because we were hung up on survival, on mortality, on arguing about reconfiguration and territorialism. And there was that kind of little green voice in the wilderness that was about quality is the real issue. And that's what brings people back together again. That's what makes it easy to collaborate in this world. So where we came from was a very, very strong, successful, rich place to be that made it feel good to be part of it. So what we were faced with in the new system, so I'm bringing us to the now, if you like, since 2013, was a very new landscape for cancer. It didn't exist in an entity in NHS England on its own. It was part and parcel of a very generic world for the greater good of the population in general, across all domains and not with one in specific area to be singled out. And that was probably right and proper to think in that way. However, it was really quite important that we didn't lose momentum. I described my first year to the National Audit Office before my Public Accounts Committee hearing, and I don't want to do another one too soon. What was life like, Sean, was a nice opener question. And I said, well, it was a bit like salvage and survival. And that's what it felt like in the first year in a new role as a National Clinical Director. But like everything else, I could phone a friend. And thanks to that, we had the ability to ensure that at least 4 key elements of the survivorship agenda would be brought through in the new system. And that was rehabilitation, reablement, exercise, follow-up models of care. And I knew I'd forget the 4th one, but it doesn't matter anyway. Thank you. Recovery package. How could I not? The recovery package. And the beauty of the new system that I think we were able to bring to bear to our colleagues in Macmillan, it was a very collaborative approach in this small bijou world of cancer at the time, was that the new system brought commissioning much closer to the grain. So cancer in the past had fantastic policy. It had about 15 years worth of Department of Health driven activity in a world which you could say, do this, and the system would respond. We were in a different world and are in. Please do this because it's the right thing to do. Yes, but you have to give us very good arguments because we've got to prioritise how we spend our pounds. So being close to commissioning meant that our job really was to take those 4 key elements of work and to see how we could package it up to make it amenable in the world of commissioning. So the first thing to do was to take a stock take. How successful had the recovery package been in exciting the attention of commissioners across the country? And it was variable and is variable, and we have that stock take. In addition to that stock take, with the help of people like Maureen Dowling and Joe, we've been able to say and identify what are the blocks within commissioning that would not mean that you could have recovery package commissioned in every part of the country. That's our aspiration. It became very clear in the generic world we couldn't recreate a cancer bubble. We had to exist in a world that everybody else is interested in. So aligning ourselves with long-term conditions was tactically sound business. But not only that, it made complete and utter sense when you started to have conversations outside of cancer. So in the world of diabetics, where they've managed to crack self-management like that, we have a lot to learn. So no longer does it require for somebody to do their blood sugars in a hospital. You just do it at the prick of your finger at home. And what can we learn from that? And we're seeing translation of that. Finger prick testing for white cell count will make a difference for every chemotherapy patient in the country. And that technology is there, and we can just learn from it. So long-term conditions, fantastic place. And you meet so many different people with so many different skills. So the here and now really is we've got about 1.5 years worth of experience in working the system, working the commissioning system, understanding our partners. It's called matrix working, but I describe it as a spider web. And as spider come in or a fly come into my spider's web, you try and connect to as many parts as the system. And I think that has helped us in our discussions coming forward and a neat segue into now the future. So the cancer strategy is about to be written and then will be published in the summer. We have a cancer task force. Our new leader, rather deftly, created an independent task force, so it's not just the business of NHS England, it is the business of 6 arm's-length bodies to deliver the cancer strategy. We have an independent chair and we've got a great group of people around the table supporting the cancer strategy. But on the back of the work that we've done in partnership, the cancer small little presence that was at the time with Macmillan and with CR UK, are in a really good place to be able to understand the language, deliver the right message, and to ensure that what we have in place in the summer is something that everybody can work with. There will be no surprises to the policy content for cancer. It will deal with screening and prevention. It will deal with early diagnosis, and it will deal with living with and beyond cancer and end-of-life care. The trick in this new strategy is the new landscape that we are in, the system that we've got. The interesting thing for me, having experienced in a very short period of time exposure to an incoming new person who's got a different perspective from the old world, i.e. Simon Stevens, is that it might be a new system, but if it isn't kind of working for you, you figure a way around it. So you start to be clever and make the system work for you. It's a bit like seek forgiveness, not permission. So our strategy will be about, in this particular agenda, trying to define, I think, a new paradigm. It's entirely nearly predictable what happens to you once you have your diagnosis of cancer. You know that there's a 10-week period during which, or thereabouts, in which you have some sort of intervention, and it could be surgery, radiotherapy, chemotherapy, a combination of all three. Why then does it come as a surprise at the end of it that something else has to happen? We've lost 10 weeks of planning. So the new paradigm, just like in early diagnosis, the paradigm is changing the culture of the first point of contact of a patient with the health service to a more proactive world that has got a system wrapped around it. It is exactly the same in rehabilitation and reablement. We've got time to plan. We've got time to plan from the moment that the referral letter goes in a 2-week wait pathway, for example. So if you're a relatively frail older person, a simple thing like a frailty index can indicate that a bit of triage might be required to undertake a comprehensive geriatric assessment. That's not just about your ability to then sustain and manage and undergo any form of treatment. It is equally relevant to what happens to you at the end of the treatment. What were the issues that led you to that position with multiple comorbidities that we then have to tackle with downstream? The new paradigm opens up new partners. Cancer can really easily deliver an integration between health and social care. In fact, airburst the word cancer out of it and just call caring for somebody who's particularly ill at this period of time. But we can use our expertise that we've gained through years of very good policy and very good evidence engagement to be able to champion how something would be very different. So as a result of our cancer strategy, I'll have a cancer program within NHS England, which is a really exciting place to be, and you're all part of it. It will not be a top-down dictation. In my view, I can report national variable statistics on outcomes for patient, be it patient experience or one-year survival or emergency presentation. But I can't deliver the solutions. You in this room can do the delivery of the solutions. And that, again, is a bit of a new paradigm. It's mainstreaming this sort of activity into the delivery. So my kind of final plea to finish this off to you is that think of it as a clean sheet. There are bits around the system that you have to deal with, but they are manageable in terms of getting around, because then you don't have to argue over it. It would be better if there was more, and maybe there will be. But, you know, it's your ability to affect change is through your leadership, through your engagement, through your bravery, and through your persistence. These are things that you don't pay money for. These are things that you rise up and do. So is this nirvana, this new paradigm, this connected system of health and social care that is so, so important for the survivorship agenda, is it a nirvana? Well, I don't think it is. I've got evidence that it's possible here. So I think my final words to you would be brave, be very ambitious and challenging, and just go for it. Thank you very much.